a nice small group, so I think it will be informal. A little bit about Project Chernobyl. So we've been in operation for about 15 years. We do a lot of work in the New York area, but a lot of the work that I'm presenting was done, in fact, by our colleagues and associates around the world, particularly in Belarus. Dr. Drost is here. She'll be presenting later something that you should definitely not miss on the recent thoughts of origins of thyroid cancer. So what I'd like to do, with your permission, is briefly give you a summary of our work over the past 10 years or so on the new approaches to thyroid cancer surgery. Doing the work that we're doing in the U.S., we work with about 200,000 immigrants to the New York area from countries such as Belarus, Ukraine, Russia, all of the areas that were covered to a significant degree with radiation fallout after Chernobyl. And as you would expect, the rates of thyroid cancer are significantly increased in that population, and thus you'll see the Belarus, Ukraine in patients who were exposed to radiation at a younger age, and then Russia, and then the Ukrainians who were exposed at an older age. And that's something that you're seeing more and more. What is interesting is that you have to compare that to the rate of thyroid cancer in the US, and that is a drastic finding. And then on top of that, as you look at other countries, what you're going to see is that, I'll give you an example of Italy, France, men and women, and then down here, the United States, and the very striking Korea. So the thyroid cancer as a disease process is something that is just escalating out of control if you're looking at the statistics in and of themselves. And so the obvious question comes, why all of this is happening, and what are the basis for these findings? And now that this has received appropriate attention, the thoughts are fairly wide-ranging. So on one hand, clearly this is an effect of better diagnostic techniques. Clearly, ultrasound findings, better fine needle aspiration, other technologies that are coming to the fore, and as well as more informed population that is coming to see the doctors at an earlier stage. And so the finding of thyroid cancer is made at an earlier stage in more patients. And so a certain percentage of the patients that we're seeing are clearly there because of increased diagnosis. However, that's not the whole answer. And so at least 50% of the patients that we are seeing with thyroid cancer, or rather I'm saying the increase in patients, is due to factors other than diagnostic improvements. And so what I think it's be interesting for you to hear Dr. Drost, who is here, present her findings. I think something, a truly revolutionary thought as to the association of nitrates, which are results of pesticide contamination in soil and water, how they may interact with radiation to give you a reasonable pathway to development of thyroid cancer. And this is something that I think you and your colleagues will be seeing more and more as the years go on. Now, most people here, I imagine, are well-versed in incidences and statistics related to thyroid cancer. Sufficient to say that the incidences are increasing. We are above 12 per 100,000 now, and lifetime risk, if you take all patients, is about 1%, so about 1% of your patients will develop thyroid cancer during lifetime. And if you take all of these patients in the U.S., that's well over 500,000 patients in the U.S. that are living with thyroid cancer. So this is a significant number. As we all know, thyroid cancer is not a killer, which is wonderful, but that also means that you have more and more patients living both diagnosed and subsequent to diagnosis and treatment, and are part of your patient base. So the other thought, the other concept to bring across is how increased in radiation exposure may also contribute to secondary malignancies. And this is something, as head and neck surgeons and scientists, we're very familiar with, but as we treat more patients with thyroid cancer. As more patients are given radioactive iodine, we need to keep in mind that they are at a higher risk for developing secondary malignancies. And this is something that, as you're developing a higher patient base, as more and more patients are living longer and longer years, this is something that you need to keep in mind. So the scientific consensus is coming together, and the thought is that if you take this problem from a scientific standpoint alone, you really do need to start looking at papillary thyroid cancer and looking for alternative ways of treating patients. It's really not appropriate in today's day and age to simply offer them surgery as the first modality. Time really has come to look at alternative approaches. And there are many institutions around the world who are looking at different cohorts, who are looking at more conservative modalities, perhaps observing more patients with thyroid cancer and seeing whether or not thyroid cancer is something that you can observe for extended period of time. An alternative philosophy, and this is something that I want to bring to the fore, is if you have patients with small cancers, or if you have patients with small tumors of really indeterminate malignant potential, perhaps there are minimally invasive ways you can treat these patients, where you don't have to take them to surgery. And this is something that we at Project Chernobyl have worked for about 10 or so years, looking at different technologies that are available, and also is developing some new technologies to try to push the idea of minimally invasive thyroid surgery. And I'm happy to bring you the most recent findings. So very, very briefly, the arguments against traditional surgical approaches are patient morbidity, cost to patient, and cost to society. Patient morbidity is simple, all related to technical issues, anatomical issues, recurrent laryngeal nerve being inside, parathyroids being in your surgical field. Those risks are relatively small. However, as you have large numbers of patients, statistically, you're going to have a relatively large number of complications. So that's just a fact. This is a well-known photo. I'm not here to judge, but I'll point out that conservatively about half of people in the photo have their eyes closed. So I don't know what, including the people who are signing the bills. So I don't know if they know what they're signing, only time will tell. Patient cost. As we talk about cost savings, and we are talking about it every day, and people in practice, people in university settings, you can't help but come across these concerns in your everyday life and medical practice. The cost of thyroid cancer surgery is extensive. You can look down the slides and start adding them up until you come to a cost of over $1 billion annually just for direct costs related to thyroid cancer surgery. Now, as you start to factor in other costs, the indirect costs related to loss of work, postoperatively, loss of productivity, these costs begin to escalate. And conservative guesses are somewhere between 2 to 4x of indirect, 2 to 4x of direct costs factored in. So you're looking at multiple billions of dollars per year that are either spent on or lost to the society as a result of thyroid cancer surgery. And so the thought that we had about a decade ago is that are there, as well as many, many other groups, is that are there patients who would benefit from minimally invasive surgical techniques? And so the clearly reasonable points are, first, you want to work on small tumors. You want to work on tumors of unclear malignant potential. So these are your FNAs where the pathologist is really not sure what's going on, and we all see them. Those of us who work in thyroid surgery all the time. You want to look at some of the younger patients, many of whom may be reluctant to have thyroid surgery. You want to look at elderly patients, many of whom may not be suitable, or you may not wish to recommend thyroid surgery for them for healthcare reasons. And the other significant subgroup are patients with either regional recurrences. So these are patients who've had thyroid cancer surgeries maybe more than once and now have a radio-resistant focus sitting on the trachea or right next to the recurrent laryngeal nerve, where you really don't want to go there again. or patients who have distant metastases that may not be very amenable to surgical correction. So if you have something where you can go and get those foci selectively, specifically, and successfully, you're golden. And so both us and I've pulled out some articles on the subject, but we've gone through all of these modalities to try to see what seems to work the best. And so cryosurgery, this really was never an effective option. And the problem, it's very good at destroying your focus, but it's impractical in thyroid applications because you need to have an exposed specimen to apply the probe to it. So as a minimally invasive modality, this works not at all. Now, radiofrequency ablation and ethanol injection is something that gave a lot of hope initially. And we first focused on the unipolar radiofrequency ablation. And there's actually a fair number of studies who are looking at this right now. Basically, what the problem with unipolar ablation is that your electrode gets ridiculously hot, and it starts to cause a lot of charring and carbonization of tissue. And so if you can keep the electrode cool, you really can get a reasonable degree of tissue destruction around it that is fairly consistent. And as you can see from this one particular study that I pulled out, very, very effective. They were able to, they did 16 patients, and in 14 of them, even with some fairly large tumors, they were able to get excellent long-term results. The one problem I've always had with this particular modality is time. As you can see, the treatment time takes a number of minutes. And to me, this was always a non-starter because I want to try to do something on patients who are sitting and breathing and swallowing in front of me in the chair in the office, not in the OR. If I have to take somebody to the OR, even for conscious sedation, to me that is defeating the point of, one, minimizing morbidity, and two, reducing costs. Because I want something that lots of people can do in their offices relatively easily. You don't need a very high learning curve where, you know, three universities in the country are doing it and nobody else. To me, that defeats the purpose. So this was not as effective, although we tried it for a while. Ethanol injection is another wonderful, very old modality, and it destroys cells terrifically. The problem with it is that it's very, very difficult to control where your ethanol is extravasating. You can put it in the right spot, but how do you know where this effect will be, how much to put in, where the destruction zone will start and stop, particularly when you're working next to vital structures, recurrent laryngral nerve, and the carotid. So again, very, very effective modality, but just not easily controlled. Ablator, many of you may be familiar, it's an instrument that allows you to destroy tissues at a relatively low temperature, so you have less pain, less charring, so in that respect it's quite effective. But the way the instrument is designed, the fact that it requires actually a steady supply of water to cool the tip and to convert it into what they call plasma is just too bulky. We had the company minimize the ablator for us, but it never got small enough that you can do it percutaneously. Just too bulky. The modality itself is not great. So we tried a lot of contact lasers, argon, and DIAG, and they never worked very well for thyroid tissue. As you obviously know, the wavelength tissue specific, and the absorption spectrum has to be just right. And thyroid tissue was just never responsive to these contact lasers. And so when the CO2 laser with the flexible fiber came out, I think we used it for about 10 years ago for the first time, it seemed like a wonderful solution. And if those of you who read the literature know that there's actually a decent amount of information now that popularizes this particular technique for thyroid. But, I'm for it, but whenever people try to sell me on that particular technique, I always think back to one of the early experiments we did in my lab, where we had one of these instruments with a nice fiber, and I had my resident ablate piece of. I think at that point we got a lot of beef thyroids to work on, and so we put it on the counter. We put it on top of a little plastic holder. We put it on the counter, and then we ablated for, I think it was, I don't know, 10, 20 seconds. I'll never forget this view. Everybody came back. We tried to take pictures. So this, the laser beam went through the whole thyroid, It went through the plastic holder and about half an inch into the bench. So not to say that it's not a wonderful modality, it is, but the learning curve is still very, very high. There's excellent Italian groups who are doing this work, but you really, really have to be highly skilled. The curve is very steep, steeper, at least at this point, than for many to be used in your clinical settings. And the other issue is time. It's still taking a lot more time to do the ablation. So we ended up settling on this little device, and this is an adaptation of something that we use in rhinology all the time. Basically, it's a bipolar electrode. And so the few things, we did a few modifications, but the key feature is that you have basically a active electrode that is of particular length, and you can vary that based on, you use different handpieces. And that determines your ablation field. So you can think of ablation zone, basically the length of the active electrode with a nice spherical zone around it. And you can control your ablation extremely, extremely effectively. And so it is ultrasound guided. We've done it on local anesthesia with very minimal sedation. There is no bleeding at all, and the pain is well controlled. The treatment time is extremely short. You can do, a patient can stop swallowing and hold their breath for about 5 to 8 seconds, which is easy enough, and that's all you need. And the destruction of the neoplasm is quite impressive. And one of the things that was a particular concern that we took a lot of time to work out is making sure that this margin, so the distinction between the treated tissue and the untreated tissue, has to be really sharp. Because if you're working next to the nerves, to the arteries, you don't want to worry that you're going to vaporize the recurrent or you're going to extend your ablation into the carotid if you're not careful. You really have to know that with that particular electrode, with that particular setting, you're going to get 5 millimeters, 1 centimeter, 1.5 centimeter ablation zone, and that's it. That it's not going to be diffused. And it seems to be working quite nicely. And so I wanted to show you one of our earlier experiments where this study was done in Belarus, and there are 88 thyroid specimens, and we're basically using the bipolar electrode in specific settings to try to figure out what is the best ablation zone. How large of the nodule can we ablate at one time? Are we destroying any surrounding tissues? And if you can see from the picture, it is very sharp. It's very discrete. The actual, the zone that goes between the destroyed tissue and the normal tissue is about 0.2 millimeters. So it's really, really sharp. And it seems to work best for 1 centimeter or smaller nodules. As you get much larger, we're also using relatively small electrode. We're not going big yet, because we're really designing this for your relatively small tumors. But if you stick to small tumors, whether it's benign or carcinoma, it works well. Surprisingly, it actually seems to work better in carcinoma. And the typical pathological findings is that you're getting, so here you see the holes, those are your needles, the electrodes. And so you have the shrinkage of the follicles, the connective tissue gets thickened, it's getting vaporized, it's experiencing current and heat and steam, basically, as the cells are rupturing. And the blood vessels are contracting, which is what you want. You don't want this propagating outside. And so, in conclusion, going through various techniques, various methodologies, our group feels that if you're looking for a strategy of addressing large numbers of people, teaching large numbers of physicians to work with an instrument, finding a relatively inexpensive technology that you're really adapting existing technology to a new application, this seems to be a very good methodology and technology to use for these purposes. And so there are various things that we could also be doing, and that's what we're exploring. We're looking at regional metastases. We're looking at improving the ablation dose by using various radiofrequency stimulators. So there are things that can be done and things that can be improved. But all in all, this probably will take its place along with other methodologies in this new field of minimally invasive thyroid surgery that's really developing over the past few years. So special thanks to to Professor Drozd, Nikolai Shiglik, who came all the way to Atlanta for us, and thank you very much for organizing this conference.
Thank you very much. Very, very interesting talk.
Any questions?
Yes, so sorry. I thought the presentation was so thorough there could not possibly be any questions, but I'm happy to answer them anyway.
I do have a question for you. Can you comment on the regional metastasis or distant metastasis and some of these cases that you have done? Have you had any?
So the problem that we've encountered, and something that is not so easy to solve, is the idea of using a lot of current in a particular area, because at some point, basically the water evaporates, and it evaporates very quickly. And because thyroid nodules do not have a discrete capsule, it's very hard to contain, and so you get this disruption of tissue. In lymph nodes, you have a wonderful capsule, and it basically retains all of this energy inside the capsule, which makes it absolutely wonderful for this type of a procedure, because you can generate a lot of heat, you can disrupt a lot of cells, and the heat is all retained within the capsule. The capsule hasn't burst from our experience, but it's going to take more work. I mean, this is not something that's, it's not ready for public consumption until time has passed enough where you can claim that you can destroy all the cancer cells, one, and two, that you don't get recurrence. Because the last thing you want is to have this scarred lymph node that now you're going to have to operate a few years later.
Of these small carcinomas that you've removed, how many have you had distant metastasis or regional metastasis diagnosed post-treatment?
We do not have enough clinical data to speak of, not long enough. This has only been in the outside of laboratory for less than 5 years. So
It's amazing. It's amazing because for me, minimally invasive meant a small incision, but this is fascinating. Absolutely fascinating.
I've done stapes used to be my favorite surgery when I was a resident, so I appreciate work in tiny holes.
That's amazing.